I think we have 5 more minutes. Aditi, you checked your slides are running?
Yeah, ma'am, shall I share the screen?
Yeah, you just try it, then you go back when madam will introduce sir. So
Yes,
just check it so that last minute we don't waste time.
Yes, ma'am. Yes, ma'am.
Yeah, we can see the slides. It's try slideshow. Yeah, change the slide. Just go to the next slide. It's not changing, huh? Yeah, now it's changing. Okay, go back. Yeah. Yeah, you can stop sharing for some time and then come back. Yeah, it's changing now. I think just go back. Yeah, okay. Yes.
Good morning, Dr. Mishra.
Good morning, Rohini.
Ah,
How are you?
I'm good. I'm good. You're looking very well.
Yes. If look is not deceptive, then I am okay. तुम कैसे हो?
Rohini, you're muted. Unmute yourself. I think I'll just call her because, yeah. Now you're okay, I think.
Yeah.
Sir is asking you, आप कैसे हो?
हाँ, मैं अच्छी हूँ, sir. Sir. हाँ.
So, who are the others in the pictures? I mean, Kavita Krishna, where is she? Is she working with you?
No, sir. I'll introduce myself. Yeah. I'm Dr. Kavita Krishna. I'm from Pune. So we are running the DM course in Bharati Vidyapeeth Medical College. I communicated with you initially.
Right.
Yeah. So I'm the professor and head. Dr. Sandeep Kansurkar is associate professor with us. So we have started the DM course almost the same time as your college, I think. So we have 2 DM seats. And Dr. Rohini and Aditi are there at Mumbai. They are Hinduja Hospital, Mumbai.
Okay.
And Aditi is a DNB student. And Hinduja,
Can I just take a call from my resident?
Yes, sir. Sure, sir.
Hello. Good morning.
We'll start in 5 minutes. No?
Yeah. Just inform secretary. Okay. Oh, so this is a Mumbai Pune
Actually,
collaboration.
Yeah. So 1 minute. Yeah.
Yes, sir.
Yeah.
This is
I'll do
activity
that. I'll do that.
Maharashtra Rheumatology Association.
And you do it every week or every month? Because we get WhatsApp
Yeah, sir. So
circular notice. I think it's very active. Because
so we have this Maharashtra Rheumatology Association where Dr. Rohini is the president right now. And we have this student-teacher interface. This is once a month activity. It's going on since the last 3 years, actually. And we have students of DNB, DM Rheumatology, and we also have the fellows, who are doing 2-year fellowships in different centers. So by rotation, we tell them to present a case, where we have senior teachers like you, chairing the session for the case presentation. So the first 50 minutes, we have a case presentation, followed by a guest lecture. So today is Dr. Ashish Mathews from CMC Vellore, who will be taking a guest lecture. So today you and Dr. Sandeep will be the main chairpersons for the case presentation. And Dr. Rohini, myself, or any other senior teachers who join, they can chip in with the questions in between. And Aditi will go to the slides. And since it's virtual, you'll have to have a PPT. And you can stop her in between. So the flow will be history.
Aditi is what? She is a
DNB student.
Or she's
a DNB student of 2nd year, no?
Yes, ma'am. Good morning, sir. I'm Aditi. I'm from Hinduja Hospital, sir. And I'm a 2nd year DRNB trainee, sir.
Okay.
Yeah, so she will be presenting the case, and step by step we can go with the history, examination finding, whatever she says, investigations, and you can ask her questions in between, and management we can discuss. Only thing, we'll have to stop at 11:50 because the guest lecture is also there. So we
Right.
can start, Dr. Rohini.
I think we should start. Yes.
So, good morning, everyone. I welcome you all to this Sunday morning session of Maharashtra Rheumatology Association Student Teacher Interface. Today, we have a very senior faculty, Dr. Ramnath Mishra. He's the Dean Research and Development, Professor and Head Clinical Immunology and Rheumatology, Kalinga Institute of Medical Sciences, Bhubaneswar. Formerly, he was Dean, Professor and Head Clinical Immunology and Rheumatology, SGPGI MS Lucknow. He's a master's in from APLA 2020, FAMS 2019. SR Naik Research Award was given by SGPGI MS in 2017. He's received the MN Passy Award by IRA in 2013 and Samantha Chandrasekhar Award by Odisha Vigyan Academy 2010. He's FRCP from London in 2009 and ICMR Talent Research Fellow in 1979. He has 225 publications and high index 44. So we are really honored, sir, to have you today for the case presentation. Along with him, we have Dr. Sandeep Kansurkar, who is from SGPGI also under you and now with us at Bharati Vidyapeeth Pune also. So Dr. Rohini, you want to add anything?
No, I think he's done a lot of work on the ITA score. So I think that's, and our case is somewhat related to that. And so we thought we'll have the expert on our panel. And
so welcome everyone for today's session. And I request Aditi to start the presentation.
Sure,
I
ma'am.
just wanted to add that, in most cases, most of our presentations, case presentation doesn't happen. And that's why we've chosen this this format of meeting wherein the DNB gets to present a case. Okay, I think we should start.
Shall I start, ma'am?
Yes.
Good morning, sir. Good morning, ma'am. So, my patient, Miss XYZ, a 24-year-old unmarried female, who is a biotechnology student studying in Ahmedabad, resident of Thane, presented to the OPD on 14th of August with a chief complaint of headache for 2 days. Patient Miss XYZ developed a sudden onset moderate holocranial headache 2 days back after getting up from sleep. The headache was non-progressive, dull and boring in character with uniform intensity throughout the day. It would not be alleviated by sleep. It was relieved temporarily by taking paracetamol, but it recurred. However, there was no history to suggest migraine in the past or no history to suggest migraine as of now, like nausea, photophobia, phonophobia, or aura. There were no local involvement of either the eye, the ear, or any dental infection to call it a focus for the headache. There was no history of any chronic painkillers, oral contraceptive pills, or consuming any drugs or alcohol a day prior, and no history of hypertension. However, 1 month back, while attending her class in Ahmedabad, she experienced dizziness. Her roommate noticed that her speech had become slurred and there was a facial deviation to the right side. However, there was no limb weakness, seizures, loss of consciousness, bladder or bowel incontinence, or tingling or numbness in any limbs. There was no history of blackout, diplopia, or hearing loss. There was no history to suggest any infective focus like meningitis or any chronic symptoms or to suggest COX. There was no features pointing at any cardiac etiology. There was no history of DVT or blood clotting in the past or any recurrent such TIAs or strokes. There was no history of any promiscuous sexual behavior, and there were no features to suggest any major underlying vasculitis which was going on or any connective tissue disorder that was going on in the background. There was no history of any head trauma, no blood transfusions or major surgery in the past or anything to suggest any toxin or drug exposure. So she was taken to a nearby hospital, and by the time she reached the hospital, all her symptoms had resolved spontaneously in less than 15 minutes. In that hospital, she was admitted for a period of 5 days, 3 days in intensive care unit and 2 days in wards. And on admission, her BP was found to be 150 by 90 mm of mercury, but eventually it normalized in 2 hours with the subsequent readings coming normal. She underwent blood tests, studico, MRI of the brain, and she was told that there was a narrowing in one of the arteries supplying the brain on the right-hand side in that MRI report. In ICU, she received pulse corticosteroid injections for 3 days and later was started on prednisolone tablet, 20 milligram to be taken thrice a day. She was also started on aspirin and a statin. She says that all her symptoms had settled before the admission itself, and she was asymptomatic during the hospital stay. On the 5th day post-admission, she was discharged on aspirin, statins, and prednisolone, which she is also currently on. Her current dose of prednisolone is still 20 milligram thrice a day. She had traveled to Mumbai for further treatment. There was no contributory or significant past history, or there was no family history of young hypertension or getting strokes at a young age, or there was no contributory personal history as well. So to summarize on history, this is a 24-year-old female who, with an episode of a transient ischemic attack 1 month back, with a history of one recorded BP being high, who has come down to the clinic now with 2 days of sudden onset holocranial headache. So I would consider the causes of young hypertension or young stroke like essential hypertension or a cardioembolic event that occurred, or any infective cause or a hematological cause to explain it, could then consider any vasculitis or any connective tissue disorder along with Apla syndrome or any congenital issue. Hello?
Yes, yes, Aditi.
Yes,
You are
sir.
done with your history?
Sir, I'm done with my history, sir.
Okay. So I just wanted a clarification again, 1 or 2 things. Why patient was admitted to ICU?
Sir, possibly in that setup, I'd asked the patient that since you didn't have any symptoms there when you went, any particular reason why you were admitted there? She said because of the investigations which were done there and the MRI which had showed a stroke, like not a stroke, a changes of ischemia. That had come. So that's the reason she said she was put in the ICU. Maybe it would have been the hospital protocol, sir.
Okay. And what the maximum
Or
blood
for
pressure?
monitoring of blood pressure. Yes, sir.
Observation.
Yeah. And what was the maximum blood pressure that she had?
150 by 90, sir. Only one reading, sir, in the day when she went to the casualty, sir. So subsequent readings were absolutely normal. So there's a possibility that it would have been like a reactionary BP rise that would have happened in this episode. And they should ideally do ambulatory BP monitoring. They should have advised there to check that. They have recorded BP readings subsequently in the hospital, which were also completely normal. So they had not started any antihypertensive over there, sir.
Misha, sir, do you want to ask?
Yeah, I just want to know whether there is vascular compromise in other arterial system. Means, does she have claudication pain?
Yes,
or upper limb or lower limb?
Yes, sir. So she does not have any history of any upper limb or lower limb claudications or postprandial angina or a syncope or even neck pains, back pains, which could be common. So or any previous such headache, there is no, or if there is any chest pain, exertional chest pain, so nothing of that, sir. Or in either, even sometimes patients may get chronic cough or even in these, so nothing like that, sir. So
okay, what
no
you asked to elicit
systems
claudication pain of the upper limb? What did you ask her? There is no history, that's fine.
sir,
I just want to know what you
yes, sir.
asked her. Which activity
So
you
one,
asked
the
for
patient.
Yes.
Yes, sir. Yes, sir. So the patient is actually a biotechnology student. So I asked her, she writing and handwriting in classes. So that's something that they do, taking notes for a long time, writing papers. So whether she
does she write?
experienced any heaviness? Yeah.
Students don't write that many. They may be working on
So she does write,
computers.
sir.
I am not seeing anyone writing except for putting their
Does
signature.
write even.
I don't know, because students are funny these days. I have never seen. They may be carrying
Even
a iPad or a laptop, but writing anyway.
They write papers, right?
They write. Okay.
common activities are simple, like she's a student who stays alone, so she cooks. So while cooking or while
Right.
bathing,
Yes.
so these are also activities
Yeah.
which I've asked
Functional
for.
activity,
Even like that.
most
Yes.
likely a repetitive activity.
Yes, sir.
Right. And claudication of the lower limb, you have checked, you've asked her if she walks down to her college, or does she walk down to a college, or she
She
uses...
walks down to the, no, sir. She walks down to the college because she stays in a university campus, sir.
Okay. And she is not limited, or she is not limited by pain in the lower limb?
No, sir. Nothing like that, sir.
And is this the first episode
So
of
this was all, sir, pretty unusual.
Okay.
Yes, sir. This is the first episode of headache,
And
sir, and first episode of
while
TI, sir.
considering some possibility, you suggested an infective cause. Which infection you are having in mind to replicate this observation of headache, TIA, which improved? Which infection you had in mind?
So, so bacterial infection is a little less likely because she has no other history to suggest. She would have been much more toxic. Like she would have had
No, I want
photophobia.
you to say...
Viral, sir. Varicella, sir. Varicella is something that can cause even narrowing TIA-like episodes, sir. But they are most commonly seen in the posterior circulation, sir. Vertebral artery involvement is possible in past varicella, which has come now, sir.
And
Or promiscuous sexual behavior, sir.
which connective tissue disease you thought?
Sir, APLA, sir.
One is APLA.
Antiphospholipid antibody syndrome, sir.
Okay.
And apart from that, there can be other causes, sir, to suggest headache or
No,
even
I
TIA
want
in
you to
connective
know
tissue. But
which are the other causes, because
yes,
when
sir.
you say other, you are
Yes, sir.
asking us to think the
No,
causes.
sir.
Why
Yes, sir.
don't you help us? What are you thinking? Is it
Yes, sir. So
which disease you have in mind?
Yes, sir. One, it could be with a connective tissue disorder, it could be antiphospholipid antibody syndrome. Second, if it is vasculitis, it could be a large vessel vasculitis given this age like a Takayasus. Second, it could be, third, it could be something like a Behcet syndrome. Fourth, it could be pachymeningitis, along with which is causing headache now with a TIA, which can be seen in sarcoidosis or a granulomatosis with polyangiitis, or extremely less likely, it could be even a polyarthritis nodosa. Also, there could be other non-vasculitic causes like RCVS, reversible cerebrovascular.
Let's go by one. Suppose it is, you thought it is Behcet. What
Yes,
will
sir.
you ask in the history for Behcet?
Yes,
What
sir.
will you ask?
So for Behcet, sir, the patient would have had a history of orogenital ulcers, or a past history of DVT, or skin lesions like erythema nodosum, sir.
And
or
how would the patient know it
uveitis,
is
sir.
past history of DVITs? How do we ask for history of DVT?
Yes, sir. So we asked the patient if she had any sudden onset of pain, redness, blurring of vision, photophobia.
Did you ask this to the patient? I mean,
No, sir.
all these we are
While asking
discussing.
her, sir, I had asked her I had asked her in her local language, which she could understand, if there was.
But you took the history, whether there was sudden history of onset of pain and swelling in the leg.
Yes, sir.
You did check
Yes,
this
I did.
point.
I did, sir. Was there a redness or a
Okay.
sudden pain in her limb causing swelling?
And something pachymeningitis, you said. Which disease is that thought of?
So, sir,
SLE.
no, sir.
Then?
Sir, sarcoidosis or even granulomatosis with polyangiitis, sir.
Okay, granulomatosis with poly. But what do we ask in the history to find that it is not, or it is not granulomatous polyangiitis? What are more common features of?
Often, yes, sir. So often patient will have systemic
It
manifestations.
is a
Like
small vessel or a medium-sized vessel or a large?
small
vessel.
vessel, sir.
So
Possibly
what do
small.
we ask to find if the patient has granulomatous
So
polyangiitis?
she'll have recurrent episodes of upper respiratory tract or lower respiratory tract infections, nasal stuffiness, a feeling of a blocked eustachian tube, or sometimes even epistaxis or hemoptysis, or
Right.
even,
Fever.
yes, sir, fever, weight loss,
Yeah.
IREC.
Systematic features are
eye
important.
manifestation. Yes, sir.
So we generally start with fever, any systematic features such as fever and weight loss. Well, it's fine. You mentioned all, but I just want you to impress upon the fact that we go by commonality of features in a particular disease to take us through.
Yes, sir.
Yes, you know it all. It's just that how important you give to which symptom.
Yes, sir.
Right, fine.
Aditi,
Yes,
so
sir.
you told in your history that she was told that some artery was involved. Which artery
Yes.
you are suspecting in this thing might have been involved?
So it could have been the carotid artery, sir, or the vertebral artery, sir, or the intracranial, the ICA, sir, internal carotid, sir. Either
Would
of
it
the three possible.
would it cause reversibility? I think
So
none
that
of
is
the
something,
none of the
yes,
arteries
sir.
that you have told are involved.
Yes, sir. Sorry.
I think none of the artery that you have told is actually involved in this case. So can there be reversibility in arteries you have told?
Sir, that is a little bit unlikely, sir. Meaning, if there would have been the first differential, that's why I said could be a cardioembolic like episode that I would consider in her, sir. So
No, that's not your first differential. If it is your first differential, then it's you are talking about a case where you are talking about arterial obstruction. You are talking
yeah,
cardioembolic.
so arterial obstruction, then I would keep Takayasu because of the narrowing, or there could be atherosclerotic plaque sitting on that narrowing also, which would have dislodged. That is also a possibility, sir.
I think you are getting carried away towards atherosclerosis or other entity. Look at the age of the patient.
At this
Yeah,
age.
So then
I would,
Takayasu arthritis, sir.
I would give a clue. I would suspect none of the artery that you have involved that may be involved. It may be a subclavian artery which may be involved. Can it be the possibility?
Yes, sir, like a subclavian steel, sir. But then the patient would have had symptoms of claudication, sir, which the patient did not have.
Yeah, it may not be present in initial stages, and in these are the situations where patient will typically present with a short duration of neurological weakness or dizziness, and after that the dizziness will go away. So
Yes, sir.
yeah, and you may not find anything active in the imaging in those
Yes, sir.
situations. So
Certain
what does
things
really
called
happen?
Can you get a TIA in Takayasu's or not?
Yes, you can.
It's quite common to get TIAs even in a Takayasu situation, because there can be a thromboembolism from the involved vessel.
So what happens in Steele syndrome exactly?
Yes, sir. So what happens in Steele syndrome is the subclavian is involved, but it is proximal to the origin of the vertebral artery. So if the patient uses, say, her upper limb repeatedly, then because there is an obstruction from subclavian and the blood cannot go to the upper limb, the body basically steals the blood from the vertebral artery. So the patient gets dizziness. So the way to elicit that history is any repetitive movement gives a transient dizziness or a syncopal episode which immediately recovers. So
I think that's what Dr. Mishra actually wanted to know from you
yes, sir.
in the
Yes, sir.
initial question.
Yes, sir.
certain things that cause cerebral hyperperfusion temporarily could be while driving the car, turning the head, washing the hair. These cause transient cerebral hypoperfusion.
Yes, ma'am.
I think we'll go to examination now.
Yes, ma'am. So on examination, patient was conscious, well-oriented to time, place, and person, well-built and nourished, febrile. Pulse was 100 per minute in right radial artery in supine position, regular in rhythm, volume, character, and without any radial or radiofemoral delay. There was no carotidynia. On the other pulses, the carotid on the right was felt weak. Rest of the pulses were okay. The blood pressure, forelimb blood pressure there was no significant difference. In the right upper limb, it was 140/80, left upper limb and subsequent were systolic 150 and left upper limb had 90, rest was 80 mmHg. There was a bruit in the right carotid. The rest of the bruits were absent. There was no pallor, icterus, cyanosis, clubbing, edema, lymphadenopathy, and RR was okay. In oral cavity, the eye examination, the nails and the skin examination were they were normal, sir. There were no features to suggest there was no erythema nodosum or any other nodules. There were no systemic features of any rheumatic heart disease. And CVS examination, it was a normal precordium, sir, and the S1, S2 was normal. There was no murmur. In CNS examination, there was no focal neurological deficit, and the fundus examination showed no papilledema, and rest of the systemic examination was normal. Hello?
Yes.
Yes, sir. So a diagnosis at the end of history and examination is possibly a large vessel vasculitis with a transient ischemic attack without complications of cardiac failure, valvular abnormality, likely to be Takayasu's arteritis.
Involving which artery?
Sir, possibly it is a carotid artery, sir, Numano type 1, sir, possibly.
Because that carotid artery pulse was weak or feeble, you said?
Yes, sir.
Okay. And there was a bruit?
Yes, sir.
Okay. But the left carotid was normal?
Yes, sir.
In the fundus, you said there was no papilledema, but what about the retinal vessels?
Yeah, sir. So fundus was normal, sir. What I've looked for is, sir, papilledema.
Oh, you described a major abnormality, but
the retinal vessels were normal, sir. Fundus was done in the patient, sir.
Right. Okay. And there were no exudates.
No, sir. There were no exudates. There were no features to suggest acute hypertensive like event or even underlying chronic hypertension, sir.
And
no features of Takayasu like retinal vasculitis or PV.
Where else you looked for bruit?
Yes, sir. So
where else you looked for bruit?
Yes.
You may have looked for the left carotid. I just want to know, in your extensive search for bruit, where else you placed your stethoscope?
Yes. So carotid, sir, subclavian, then brachial, sir, then iliofemoral, sir, aortic, sir, and renal, sir.
Where did you place your stethoscope for the renal bruit?
Sir, just above and slightly lateral to the nevus, sir, the navel area, umbilicus.
Okay, just above and lateral.
Just lateral, sir. Yes.
I thought a more appropriate place would be if you join a line between the umbilicus and the anterior superior spine, 1 inch below the umbilicus on that line, or 2 centimeters or so. You placed it just lateral and just above. You
Yes,
said
sir.
above the umbilicus. And where you look for bruit of the descending aorta, or
the blades of descending aorta, if it is a young patient, then just like in the midline only, above the umbilicus, we can look at. But if it is a relatively like obese patient, then we can ask the patient to turn on one side and look between the blades, like
which
posteriorly.
blades?
Sir.
Which
Blade of
blade?
scapula, sir, will be
Oh,
thoracic aorta.
scapular blade.
Will be thoracic aorta, sir. And below that.
Well, actually, the bruit that is heard there behind the chest, between the scapula, is not arising from the aorta. They are because of collaterals. The descending, if a part of the aorta, the thoracic aorta is obstructed, a lot of collaterals open up. So you are hearing the bruit there and not directly from the aorta. The aorta is a deep placed vessel. And you also looked at the iliofemoral?
Yes, sir.
You mean the femoral?
Yes, sir.
The
Femoral.
iliac, which one you mean, the external or the internal iliac?
External, sir.
Must be that, it must be the femoral. Is easier
yes, sir.
to.
Femoral, sir. Yes, sir.
When you said iliofemoral, I don't think your
Sorry, sir.
I don't think your diaphragm is large enough or deep enough
No,
to
sir.
hear the
Sorry,
iliac. Right. Okay. Fair enough. What are the possible differential diagnoses now? One is Takayasu. Which other disease can affect the right carotid artery or a branch, primary branch emerging out of the aorta? You had many different
yes, sir.
diagnoses.
Yes, sir. Yes, sir.
At the end
So
of
it could be,
fistula.
yes, sir. Yes, sir. So it could be variable vasculitis, sir. Either Behcet syndrome, sir, or Hogan syndrome, sir, or relapsing polychondritis. Or since she's a young girl, even there is one remote possibility of her having fibromuscular dysplasia, sir. Or even connective tissue disorders like rheumatoid arthritis or SLE can involve or giant cell arthritis, but all these are unlikely, sir, at the end of history and examination.
So, if they are unlikely, why mention them? Like rheumatoid or SLE. She does not have any features in the examination.
Sir, yes, sir. So at the end of this, sir, the most likely diagnosis would be large vessel vasculitis, sir. Most probably Takayasu's arthritis.
Right, right. And what do you mean by variable vessel?
So by variable vessel, I mean any small, medium, or large vessel involvement could be possible.
Yeah, it is possibility there, but in this particular case,
no, sir, because she doesn't have any other features, sir.
No small or medium sized vessel.
No, sir, not in this patient.
So your thinking is now focusing only on one disease, Takayasu.
Sir, as of now, yes, sir.
Had it been a different age, say it was
giant cell arthritis would have been a possibility, sir.
And which vascular territory is affected by fibromuscular dysplasia?
Yeah, so mostly it is there are two variants actually. There is multifocal or a unifocal variant, and mostly it is the renal vessels which are commonly involved. After renal, it is the internal carotid which could be possibly involved. But the patients who have CNS involvement, most of the times do have a renal involvement. So
right, okay. Fine.
Yes.
Now we can go forward.
Yes,
let
sir.
other people. I mean, other examiners or other assessor ask
Just said
you
one
questions.
question. Yeah,
Yes,
Aditi,
madam.
in spite of absent pulses, why Takayasu's patients don't get any digital gangrene?
Yeah, ma'am, because it is actually a slow process that happens. So usually there is formation of collaterals. A good collateral formation happens, ma'am. So unlikely that they get, yes, ma'am. Though there are very rare case reports which have been reported of even a gangrene coming up. I think like from AGPJ, yes, ma'am.
Sandeep, you want to ask anything? Yeah.
Could you resolve the cause of headache till so far with your history and examination?
Sir, so one cause could be raised blood pressure, sir, but I couldn't actually pinpoint to we have asked the patient to do ambulatory BP monitoring, sir, at home, because it's again one reading taken at the clinic, sir. So
what are the clinical examination findings which can tell us whether she has got a chronic hypertension or not?
Sir, so she would have fundus. The fundus examination was completely clear, sir. So she would have had changes there, sir, to suggest chronic hypertension.
Hypertension.
Apart from fundus?
Yes, ma'am.
Apart from fundus? On
Well, like in this case, ma'am, renal
cardiac
Cardiac.
examination.
Well, yeah, then LVH, ma'am, features of LVH on cardiac examination. So the apex beat would have gone down and out, which has not happened.
Okay.
And
You
ECG?
did not mention where is the apex beat?
Ma'am, sir, I have mentioned, sir. It is in the 4th and 5th intercostal space, sir, inside.
Did you mention that?
Yes, sir. I have, sir. Yes.
Okay, then probably I missed it. But yeah, that is if we can do an ECG to
ECG.
find out.
Yes, sir.
To
ECG,
find out.
sir, and 2D echo.
In ECG, what will you look for if it is a left ventricular hypertrophy? What are the characteristics?
Sir, features of left ventricular hypertrophy, like the
that?
lateral leads in the so the P
No, I am looking
QRS
for
complex.
What is
will be
the
much
height?
taller.
What
Yes.
is the height of the QRS complex in V4, V5?
Voltage criteria.
It
What
is
is the
actually
volt-
Sokolow-Leon criteria, sir. And we add the value, sir. V1 plus V5 more than 35, sir.
35, good. And if it was alone V1?
Alone, sir, I think it's 20.
Any R wave, you
Yes,
don't
non
expect
R-wave.
in the V1.
yeah, any R wave.
R
Yes, sir. Yeah.
You know it all. I think you know it all.
Yes, sir.
मेरे को criteria फाइटे मत बताओ. I just want
Yes.
in a bedside, suppose the ECG strip is given, what we are looking for.
Yes, sir.
Let's just go on to investigations. I think you've got slides
Yes.
on that. Yeah.
Yeah, ma'am. So in investigations, the first column are the investigations done at their center. So in that, hemoglobin was 12.2, MCV 93.
Why am I not able to see the slides? Have you not shared the slides?
I have, sir. Should I share them again, sir?
Because neither I am able to see you, or shall I reconnect?
Yes, sir, because we are able to see actually.
It's not by design. You don't want me to see the slide.
No, sir.
You can maybe disconnect.
Let me rejoin. I think I'm not able to see the slide.
Yes, sir. Please rejoin.
And missing the fun.
Will you postpone that a little bit, Kavita?
Sorry?
The lecture?
Yeah, I'll just tell Dr. Mathews. Yeah. I'll call him and I'll tell him. Yeah.
Yeah, I'm back.
Sir, now, sir, is it visible, sir?
Can you see the slides, sir?
Yeah, I
So
can see the slide.
Okay, okay. Aditi, carry on. Yeah.
Yes, ma'am. So the first column, the investigations have been done at the outside center, ma'am. So hemoglobin was 12.2, MCV 93, total leukocyte count and platelets were normal. ESR was 43, HSCRP 3.5, ma'am. Globulins 2.5, creatinine was normal, electrolytes were normal. Homocysteine was raised at 32. ACE levels were 75. ANA by IF ANCA was negative. Urine RM had no RBCs or proteins. Serum lipids were normal. Complements were normal. 2D echo did not show LVH. The triple H was negative. APLA profile had been done, that was negative. And X-ray and ECG was normal. So the MR findings noted here where they had done an MRI brain there 1 month back that had multiple discrete small sized non-hemorrhagic infarcts in the right basal ganglia and also in the frontoparieto-temporal and occipital lobe without any midline shift. There they had done a MR angio, and in that MR angiogram that they had done there, they had in the right side there was mild narrow caliber with mild concentric homogeneously enhancing wall thickening in the distal common carotid artery and near complete occlusion of the internal carotid artery from its origin with mild concentric homogeneously enhancing short segment wall thickening at carotid bulb and proximal ICA for a segment of approximately 16 mm. So this is the figure. So here if we see, this is the branch. This is the where my pointer is actually the vertebral artery, which is going like this. This is the common carotid, and this is actually the bifurcation, where from here is the internal carotid, and this is the external, which I'm tracing right now. If we see on the normal left-hand side, we can very nicely appreciate the internal carotid going and here, whereas here it is absolutely not visible. And even on the image on the right, this is the internal carotid, which we can appreciate. There is nothing here. So one thing that I would want to point out here in this report is there are some very odd findings which do not fit with my diagnosis at the end of examination and history. So the report here says there is concentric homogeneously enhancing wall thickening, which may fit, which fits my diagnosis, but it is involving the distal portion of the common carotid artery. So that is very odd for Takayasus. A Takayasus should have ideally involved the branches coming out of the aorta, the big branches. So this should have been the proximal common carotid in that case. Secondly, a near complete occlusion of internal carotid artery from its origin with mild concentric homogeneously enhancing short segment wall thickening at the carotid bulb and proximal ICA. So this can also somewhat fit with the diagnosis of vasculitis. And yes, it is a large vessel, so it is again large vessel, but to have ICA involvement without a proximal CCA involvement or involvement elsewhere is very odd for to make a diagnosis of Takayasus. Another thing that they had done there is the MR aortography. They had looked if, even though the patient did not have any clinical features to suggest involvement elsewhere, to look at what the extent was. They had done a aortography, and in that it was reported to be subtle surface irregularity and minimal mural thickening in few proximal jejunal and ileal branches of the superior mesenteric artery. So again here what I wish to point out is the mural thickening does fit in a few, the proximal vessels does fit, but again there is no involvement of the mesenteric arteries. It is of the branches, jejunal and ileal branches. also segmental renal arteries are involved, which are actually tapering branches, which are point towards a small vessel. And the further description, like there is mild tapered narrowing, again that points towards a vasculitis. But whether at the end of like we can't call it Takayasu's, or we may call it like a early or a evolving vasculitis at this point of time after imaging. So we did a whole body PET scan, and we actually discussed all the above scans with the radiologist at our center as well, because we found this very, very odd. So this PET scan, again, I would like to add here that it was done when the patient was on prednisolone of 60 milligram per day. So there was no metabolic activity elsewhere apart from the right internal carotid, and she had come to us with headaches. So ultrasonography was done with a renal Doppler, so that was normal. Carotid Doppler is actually awaited. So at the end of all these investigations, I would like to change actually. My diagnosis that I had thought of initially, to it could be a large vessel vasculitis with TIA without complications of cardiac failure or valvular abnormality. But as of now, I cannot pinpoint and say that yes, this is Takayasu's, though likely it is Takayasu's. So to say that, we look at the ACR ULR 2022 classification that had come. So one is absolute requirement. So does my criteria fit absolute? That itself is a dilemma. Age, yes, it fits. Evidence of vasculitis on imaging, I do have, but there is a disclaimer here that it should have the vasculitis on imaging of aorta or any branch artery. So in branch arteries, the common carotid is involved, but it is involved distally. Second, additional clinical criteria that I have is female sex, agree, no angina, no arm or leg claudication, vascular bruit. Yes, I have got reduced pulse in upper extremity. So, and a carotid, so that I have not got a carotid artery abnormality. Yes, I have got that. And a systolic blood pressure difference of more than 20 mmHg, which I have not got. As far as the previous, it used to be in the 1990 criteria, it was more than 10 mmHg, but here it doesn't classify. Additional imaging criteria again is a dilemma, because the number of affected arterial territories 1, 2, 3. So yes, the arterial territory is affected, but that is not what is said. The proximal involvement is not there. Like the mesenteric vessel should have been involved when we calculate that. The proximal carotid should have been involved when we calculate that. So are really 5 points classified in this case is a query, because even though abdominal aorta involvement with renal or mesenteric involvement is +3 points, it is the proximal or the one which has to be affected and not the distal. So these are the differentials. Though the commonest that I would still place will be possibly a early Takayasu like vasculitis that we are seeing, or maybe the patient is evolving, so she may have other systemic manifestations which would come in picture later.
Yes, sir.
I agree with what is Aditi's contention. It can't be classified as Takayasu because the proximal part of the primary aortic branches are not involved. I even can't say that it's the early Takayasu, because studies have shown that it is the point of origin of the branches from the main aorta that gets affected first. It is
Yes,
not a distal to proximal disease. I am at a loss to call it psychiatry. I mean, besides this classification criteria of ACR EULAR, basically you need to have a segment which is in proximity to the aorta, at least 2.5 centimeter within. And these are, in this particular lady, all the affliction has occurred much distal.
yes, sir.
I I can't call it psychiatry
Yes, sir.
at this point of time. And
Yes,
I also don't think that in future the extension will occur toward the proximal part of the aorta. If anything, it will go distal.
yes, sir.
That is seen in the intestinal vessels.
Yes, sir.
I would like comments from others. This is definitely vessel involvement, probably inflammatory disease, but I I can't at this point of time call it a PAS.
Maybe Aditi can show your differentials, your points and against without much of repetition. We've already discussed most of them.
Yes, ma'am. Most of the points, I mean, ma'am, we have discussed like it is some large vessel involvement, large vessel vasculitis, which is possibly evolving. So points which are favor where the young female clinical carotid being weak or bruy, raised inflammatory markers, and that imaging is very classical of a vasculitis as well. So points which are typical, I've already mentioned that there is no proximal involvement anywhere. Another is variable vasculitis, but then we have no other systemic features to call it IgG4. Again, usually IgG4 is in males. It is not that young, ma'am, in 30s or more than 30 to 50 age group. It is more in males. It is usually periaortitis that we get in IgG4, and aneurysms are much more common than such stenotic. Those stenosis is also reported, but aneurysms are much more common. Again, regarding fibromuscular dysplasia, we discussed that even though there is a unifocal variant, to have absolutely no renal involvement, but to have such involvement in the jejunum, or this is very odd for fibromuscular dysplasia. Inflammatory markers are high, so that is odd. So acquired moya, but then again unilateral, and it is extra cranial also, like in jejunum, so that is out. Another thing is something like intracranial pan, but then again micro aneurysms are much more common. There would have been other features, and age, gender, all that doesn't fit. Then any CTD related vasculitis, again, we don't have any systemic features. RCVS, I had considered not like deep down because of her first presentation, like TIA or the young female and the headache of sudden onset. But then the headache is very classical, like a thunderclap headache that we get. Imaging again is not fitting. You'll have small vessel involvement there. Inflammatory markers are raised, so that doesn't fit. Infective pathology is again unlikely. There are no other features. Hyperhomocysteemia is one really remote possibility. There we may get narrowing if it is there for a really long, prolonged time. But usually we chase this in patients, like in young patients where there are MTHFR mutations which happen. So usually the cutoff that hematologists take is often homocysteine more than 50. So that's when they do a MTHFR mutation. Again, a heterozygous single mutation would not mean anything. You will require one more coagulable factor along with that to cause a thrombosis or event like that. But long-standing narrowing is known. It's a very, very rare cause, but yes, it is known. in cases of hyperhomocystinemia. But then again here, a single vessel there in the cranium with not much of other vessel involvement, that is also very odd. Like it would have been more systemic. Many vessels would have been involved.
Yes, Sandeep, you would like to ask him.
So otherwise, this was a stable disease. Suppose if it had been a Takayasu or any Takayasu arthritis patient, what may be the causes of sudden worsening of the disease? What complications can occur in already existing Takayasu arthritis?
Yes, sir. So one CNS complications like stroke is possible. Second is the patient may have coarctation of aorta, dissection of aorta,
I'm
which is a
talking about
possibility.
acute complications which can happen in otherwise stable Takayasu arthritis.
So a flash pulmonary edema, if the patient has a renal artery involvement, the patient may land up with flash pulmonary edema because of resistant hypertension. The patient may have cardiac failure because of left ventricular failure is a possibility. Third is, like I said, CNS strokes are a possibility. Fourth is like aneurysm formation, which may rupture.
Okay.
Main cardiac, even coronary can get involved. So if there is coronary osteal involvement, the patient may have a young onset myocardial infarction also. So
okay.
That's when we'll think of.
Yeah. So sudden worsening of arterial obstruction, what may be the cause in Takayasu arthritis?
So like chronic long-standing Takayasu, then it can get complicated by
sudden worsening.
Then coarctation or dissection, like
dissection is
yes.
It's one of the complications which can lead to otherwise stable Takayasu arthritis.
Yes,
Sudden dissection may lead to the problems.
Yes,
okay.
Sir.
And what imaging modality you would like to use in those situations?
So in those, I agree that overall a non-invasive need to be preferred over the invasive ones.
Yes.
But in this case, it has to be a investigation which happens earlier. So a CT angiogram is something that I would choose.
Yes. And
rather than MR.
What's the problem if you go for DSA in these situations?
No, so we are not while doing DSA, we are in the vessel, so we don't know anything what is going on with the wall of the vessel. So DSA is not something that I would do.
Yes, and also it can go into the false lumen and
false lumen, and in fact worsen it further.
Dissection.
So, dissection further. So
Rohini, you could comment because it's your patient.
I think this is all that we actually discussed. And like she said, this hyperhomocystinemia, although it's, I have seen these sort of very linear long segment narrowings in antiphospholipid antibody syndrome, extremely long segment narrowing. Although we associate it with thrombosis, but when it's over a period of time, you can get long segment narrowing. So we thought of the hyperhomocystinemia as well, although otherwise the features are of a vasculitis. So I think with time we'll have to see. However, if she's on treatment, I wonder whether she will progress or what will happen. So maybe time can tell us.
How did you treat her, Aditi?
I have a suggestion.
Yes, sir.
And it's clearly very difficult to call her or label her as Takayasu at the present time. In an era where none of us used to practice medicine, the post-syphilis era, the syphilitic aortitis have also syphilitic arteritis.
Yes, sir.
And they were characterized by skip lesions, means it is not a continuous lesion like a Takayasu, a proximal to distal progression, but syphilitic vessel involvement would have aorta and skip peripheral vessels involved. Well, to call her syphilis is very difficult because at 22 years, and syphilitic vessel involvement was part of a tertiary, not the primary, not the secondary phase, the terminal. That means she was a congenital syphilis.
Yes, sir.
But it is better to get tested for VDRL,
Yes, sir.
or a better test for VDRL. VDRL is no longer used.
PH.
VDRL only
TPH.
is a very
Yes.
weak surrogate test for syphilis. They use the Treponema pallidum test. Directly you can see by immunofluorescence. I don't know,
Yes.
people may not be doing that test. It is of not commercial value. We don't
Actually,
think of.
Recently, we saw a couple of uveitis and related to treponema. And again, it seems that there is a surge of syphilis as well.
We also had one
Hmm,
patient.
hmm. And I just had a comment because it'll be reported, it'll be published very soon, but we have reported about 10 cases of intracranial involvement in Takayasus. Not that I'm saying this is intracranial, but Takayasus, but I'm just saying as a comment that it will be published very soon of 10 cases with intracranial involvement in Takayasus.
But those patients had proximal involvement.
Yeah,
No,
yeah,
no.
yeah, yeah.
No, no,
Like-
those are not like this patient. I'm just saying as a.
Aditi, what did you treat? How did you manage the patient? Because we'll have to wind up in 5 minutes. Yeah.
Yes, ma'am. So this patient, we started her on a tablet MMF 360 202. Then tablet prednisolone 0.5 mg per kg per day for a month. Then we have slowly tapered her. By 3 months, we wish to reach around 15 milligram per day, and followed by hopefully we'll be able to taper it down to 5 milligram per day by the 6th month. Then we have started her anti-hypertensive because in her ambulatory monitoring also the BP readings were coming on a higher side. So we have started her on a tablet cilnidipine, a 10 milligram OD. She is already on homocheck because she had high homocysteine levels, and ecosprin tablet, aspirin 150 milligrams we have started as of now.
Yeah. Mishra sir, your comments, questions?
No, I think we don't have randomized clinical trial for evidence of alternative drugs to prednisolone to reduce the side effect of long-term use of prednisolone. You could use methotrexate, azathioprine, or mycophenolate. I personally have used a lot of methotrexate and azathioprine. Mycophenolate, I not used, but Devashish from Vellore, they have published their reports of mycophenolate. But literature suggests one is as good as bad as the others. In the affordable group in Mumbai or Pune, you probably give mycophenolate. We are a lesser affordable group of patients. Methotrexate and azathioprine is as good. But in this particular sense, there is a little bit discomfort on me. Suppose you start the medicine, how long you need to go? And when would you have the next radiological imaging? Either if she is symptomatic for any event within the next 1 year or annually, that is recommended, because the part of the vessel that she has got affected, you can't monitor by ultrasound. You have to have MRI or CT angiography, and that cannot be repeated before 1 year. So I find it sometimes difficult. Kitna din tak chalega? How long would you like to give? Unless, of course, and your presumption is that you are trying to prevent recurrence of the problem, which is so typical of Takayasu, that is recurrence of the problem. That you will see when you are down to 10 or 7.5 milligram of
Yes.
prednisolone, because that is the only drug that tell us if you reduce the dose of steroid less than 7.5 to 10, and I agree with your tapering schedule. By 3 months, she should be down to a dose not more than 0.15 milligram per kilogram. So, वो तो ठीक है. But I'm sure at some point of time you will be also uncomfortable when the patient asks you, "Bhai, kitna din chalega?" Well, we all will be uncomfortable. We can't say 3 years, 5 years, unless there is definite evidence of progression or recurrence. We are stuck. But we are stuck in most of our daily management. We try to act, we manage. God bless you. Chalega, chalega.
So your
So
feedback on the presentation today,
we are
sir.
looking for a recurrence or chronicity. And we call it whatever, Rohini Samant vasculitis. I mean, I can't call it Takayasu or Maharashtra rheumatology Takayasu.
So your
But
feedback on the
please get immunofluorescence to Treponema pallidum test,
Yes,
if
sir.
you can.
Yes, sir.
So your
Don't do
feedback
the
on the
other.
case presentation today for the student?
No, she is too good. I mean, she's better than me at my age. When I was her age, she is any day better. I mean, I mistook her as who has done her training program.
Great.
She is too good, yeah. I
Thank you.
feel jealous of her.
Sandeep,
She
your
तो सब
comment?
कुछ जानता है.
I agree with Mishra, sir. Absolutely.
Okay,
She is very good.
Thank you, sir.
Thank you so much,
So,
Mishra
but
sir.
we want suggestions for improvement, not just the positive ones.
Yeah.
Areas of improvement, yes.
In general, I mean, in general.
You pursue the, I think there is something with the vessel wall, and that homocysteine is getting little bit
overemphasized.
I will read up something because I am in the age of senility. So I can't, like you people, suddenly think of a thing. मेरे को थोड़ा पढ़ना पड़ेगा. But there is one thing that you said, homocysteine level is high. I want to know whether there's a primary vascular wall abnormality, and it has involved diverse vessels, not only the one that is going to the cranial, but also to the intestinal viscera, the third and the second and the third branch. I mean, they go in loops. It is the second and third. ये कुछ गड़बड़ है. If I knew about it, मैं थोड़ा पढ़ के आ जाता, because usually I read up and come up for presentation. Otherwise, I'm pathetically poor in knowledge.
Anything else, Rohini?
कुछ गड़.
No, I think.
Yeah,
I think it does. Yeah.
Okay. Thank you, sir. Thank you so much for being here today. Yeah. Rohini would like to close this. Yeah, then I can.
No, Dr. Mishra is being humble as usual. But
Yeah.
no one is buying it, so it's okay.
Yes, sir. We know. So,
But it was great meeting up with Rohini, Aditi, and Sandeep, of course. मेरे को फिर ना बुलाओ. Call me again.
Yes, sir. Yes, sir.
आप मुंबई में ही आ जाओ. आप मुंबई ही आ जाओ. आपका वो था ना.
My ITAS working was not very useful today. But anyway, मैं तो उसको फिर रट के आया था कि कुछ पूछोगे तो मैं फटफट जवाब दूंगा. वो काम नहीं आया. I got to know first time Aditi also. But it was a great year. मेरे को फिर कभी बुलाओ. I mean, I feel ignored sometime. So
Thank you.
मेरे को कोई बुलाता नहीं है आज.
अरे, call you, sir. Okay, thank you so much, sir. Thank you, Rohini.
So nice of you, so kind of you. And I was very impressed with that, whatever her name, the student.
Aditi.
Maybe she has prepared well. ऐसे अगर नींद से जाग के पूछो शायद इतना नहीं बोल पाती, पढ़ी है वो. She is good.
Yes.
Yes.
On her day, she is good. On other day, I don't know how she is.
Okay, thank you so much, sir. Just,
Thank you. Thank you. Are we privileged to hear what वो आशीष क्या बोलेगा?
Yes, yes,
आशीष
of course,
का
sir. Please stay, please stay.
You are not going to disconnect me?
No, sir, no, sir. So
Okay.
we have with us Dr. Ashish Mathews. I'll welcome him on behalf of Maharashtra Rheumatology Association. Dr. Ashish, you're there? Yeah, yeah. Hi, good afternoon.
Good afternoon.
I take great pleasure in
afternoon, sir.
introducing. Yeah.
Good afternoon.
Dr. Mishra, sir, Dr. Ashish is telling you hello.
Yes, I can. He's
Okay, so
he has
Dr.
not
Ashish.
aged at all. And his hairs have not started
I don't.
growing.
No, not yet.
Yeah,
So
Dr.
I
Ashish
hope
Mathews
everything is fine with you.
Yes, sir.
All good, sir. Thank you.
Dr. Mathews is Professor, Clinical Immunology and Rheumatology, Christian Medical College, Vellore, India. He's also a Research Associate at Copenhagen Center for Arthritis Research. We are really privileged to have him today for this talk. His area of interest is psoriatic arthritis, outcome measures, imaging, biomarkers, and also MR imaging in axial spondyloarthropathy. So today we've requested him to talk on optimal application of MRI in axial spondyloarthropathy. And I'm sure all of us and our postgraduate students will be really enlightened by his talk. Dr. Mathews, over to you.
Thank you, Dr. Kavita. Thank you so much for this invitation. And it's an honor to be here today, especially with this subject, as well as with Mishra sir being listening to this. I'm honored as well as apprehensive of the questions also. But without much ado, let's start off with, the role of MRI has kind of developed over the past couple of decades now. And it's kind of transformative in our current understanding of axial spondyloarthritis. However, we need to understand that it has its own critical limitations. And whenever we talk about MRI, we shouldn't think that, that's the end of the road for diagnosis as well as treatment. And then we need to understand the critical limitations as well. So what I'm going to do today would be to just touch upon the basics, like Dr. Mishra sir was saying, leaving room for another lecture where we can go dive a little more into details of how to go about, and of course, spine, I won't be able to do in the next 30 minutes. So what I thought is I'll just get into the basics of sacroiliac joints, and then maybe keep spine and the other detailed aspects for another day if possible. So with that, I'll just dive in straight to the outline. We'll start with the sacroiliac joint anatomical considerations. I don't think I need to spend much time with this audience on this. So we'll straight away go into the understanding of ASAS positive criteria. Now, I was just listening to the previous presentation by Aditi, fantastic presentation and discussion. But again, we often go back to the criteria. I mean, we often, somehow I feel that we are so much enslaved by these criteria that we forget that we have a patient in front of us who has to be diagnosed. And the criteria is generally for, classification of a homogeneous population for clinical trials. So how do we understand ASAS? And it's the same thing for MRI in axial spondyloarthritis, because whenever we talk about MRI, the first thing which comes up, ASAS classification criteria. So we need to understand what exactly is ASAS positive, how is used and misused in this context. Now, how about the old trend radiography? It's kind of losing its sheen because of multiple reasons. I'll just touch upon that. Then we'll just dive into the basics of MRI of SI joints, the sequences. We'll discuss the inflammatory and structural MRI lesions and their definitions, not so much in detail. And again, here again, I would like to go into a bit of basics in terms of what are the other conditions where you can see a similar lesions. We'll discuss a few differential diagnoses and wind up with how to optimally utilize MRI. Now, if you look at the diagnosis in daily practice, what is the role? We know that a physician is often the diagnosis of axial spondyloarthritis. What we do in the clinics is it's an integrated aspect which contains clinical history, laboratory findings, as well as imaging findings. So imaging is always a part of the whole group and it cannot be taken separately. Pretest probability is something which often people ignore most of the times, and that differs from different population of doctors. I'm talking about, for instance, I mean, I have patients coming to me with 3 or 4 MRIs in a row, one done by an orthopedician, 2 done by a rheumatologist, the third one probably a spine surgeon. So it's always important to understand that pretest probability is has a very crucial role when it comes to ordering tests, and we need to be really conscious of what we do, as well as cautious of what we do, especially with this new rule, which is being discussed far and wide for the past couple of days. Now, so this, again, when we think of a diagnosis, we need to think of what could be, the probability of this patient having that particular disease, and then probably order the particular test. I'm just reminded of this old saying of, if it looks like a duck, swims like a duck, and quacks like a duck, it has to be a duck. And then comes this investigation paradigm. So I think we need to be very mindful of that. It's again a multidimensional process, which with the confidence level, which increases as the patient and physician, continue in the process. And it often needs reappraisal based on disease evolution upon follow-up. And ACEs criteria, like what I mentioned, is only a classification and it's not for diagnosis. And we need to be really mindful of that with the risk of overdiagnosis. Anatomical considerations, we know what we're talking about. That is the joint. These are the lengths of sacroiliac joints, what we talk about. And this is what we are going to talk about today. This is the sacral facet joint, the facet of the joint, and then we have the ilial part, and that's that's a sacral facet of the joint. What we are interested in this for today. And when you look at the sacral part, we have, if you look at the sacroiliac joint, the 2 things I'd like to focus here. One is the shape of the joint itself. It's more of it's something like a boomerang, if you were to stretch your imagination. And it has an anterior part, which is colored green, and a posterior part, which is colored blue. Now, the anterior part is a cartilaginous part, and this is where our focus is. And then we have a posterior part, which is the ligamentous part, which also do get imaged when you do an MRI, but we often restrict ourselves to the cartilaginous part. And of late, there are a lot of studies, like what I said, we're just learning this technique and the limitations. And one of the limitations is gender or sex differences in SIJ. And going back to the anatomy, this was a 3D reconstructed figure in which it shows the sacral facet of a woman versus a man. We see that it's more of a horizontal sacral joint facet in women, especially if you look at the area here versus the area here. And we see that in women, the facet is broadest at the uppermost and the middle part, whereby for men, it's kind of equally extended right from, anterior to posterior, as well as superior to inferior. If you look at the arrows, the black one denotes the superior aspect, the anterior aspect of the sacral facet, and the posterior aspect. And beyond this, what we see is the ligamentous portion of the SI joint. Now, a quick dive into the ASAS classification criteria. And this part of the ASAS classification criteria, which is called the imaging aspect or imaging part of the ASAS criteria, is what brought in fame for MRI for the past since 2009. And the whole purpose was to classify patients earlier for the diagnosis of spondyloarthritis, given the enormous number of, or an array of new medications which have been in the market right from the early 2000s, and it's exponentially increasing of continuously the number of drugs which we have in the armamentarium seems to be increasing. So with that purpose in mind, 2009, ACES developed this classification criteria. However, they modified this again in 2016 because the only pathology which was mentioned in the 2009 criteria was a BME. Now, how do we BME suspected us of or rather very highly suspected of sacroiliitis? Now, how do we define ASS-MRI criterion? We need to have 2 BMI lesions in subchondral bone marrow on a single semicoronal slice or a single lesion evident on 2 consecutive slices. Now, what is important is the location, the extent, the demarcation or intensity also comes to the picture. Now, one of the major unintended application of this particular definition has been the overdiagnosis of axis spondyloarthritis, and I'd like to stress on that a bit before moving on. And BME specificity increases to more than 0.9 if you have a series of quadrants and as well as the series of anterior posterior cuts which have this particular BME what we're talking about. Now, it's important to understand what exactly is meant by ASS positive MRI. We need to know that it has to be in the inflammatory, inflammatory changes in the SIJ, which are required, and it has to be in the cartilaginous part, not in the ligamentous part. We need to have sufficient bone marrow edema not explained by artifact or other causes. And the distribution has to be indicative of axis spondyloarthritis and not restrictive or pronounced in the most anterior portion of the joint. I'll come to that point as we move on with this lecture when we consider the differential diagnosis. However, in 2016, they brought in this whole point of having structural lesions when we think about the diagnosis of, or rather a positive ASS MRI lesion. And we need to have a constellation of findings which are highly suggestive of axis spondyloarthritis. Sounds pretty vague when you really look at those, but as we go on with the clinical diagnosis and classification dilemma, I think it's very important to understand that diagnostic process is always, like what I mentioned, is focused on a particular patient, and it's often by combination of weighted consideration with exclusion of possible differentials. So that's how we make a diagnosis. However, classification is focused for groups, for homogeneous collection of patients for research purposes, and these are already people who are diagnosed to have a particular disease. And this is right across the spectrum for all diseases. I'll just bring to you 3 vignettes by which we see how we can apply and falsely apply this criteria and fit a patient like what we do into the ASS criteria. The first one is a 28-year-old man playing badminton regularly, comes with a low back pain of 6 months. He also has Achilles tendon enthesitis and a stress-related BME in an MRI. He comes with this MRI saying that my doctor did this MRI. I was told that I have a bone marrow edema. What do I do? And here, if you look at it, actually 2 slices do have a typical bone marrow edema, which is subchondral. And this, I would say, will get the tick box, all the boxes ticked for ASS criteria fulfillment. However, patient comes back, he goes to a physio, his Achilles tendonitis disappears with NSAIDs, and he appears to be normal maybe in 3 to 4 weeks. So here we know that applying this, if you were to call it, we would brand him as, or classify, or rather diagnose him as axis spondyloarthritis, start on biologics, and then there's a never-ending story thereafter. The second vignette, we have a 32-year-old male who came with inflammatory low back pain of 9 months duration. And again, MRI was done, which showed few structural lesions. If you look at over here, we see a few erosions here. However, if you look at the stir, there's absolutely no inflammatory lesion. And the CT was done because of this, and this also showed few erosions. So in this, the gentleman, although he has clear-cut axis spondyloarthritis, if you apply the criteria, he cannot fulfill the ASAS criteria. Again, the third one, 46-year-old man, 6 years history of low back pain, inflammatory in nature, B27 positive, has enthesitis and dactylitis. If you look at the conventional radiography, all you see is a calcification over here, but his joint seems to be perfectly fine. Of course, there could be doubtful sclerosis, but overall, there are no erosions. But the same gentleman, when he underwent MRI, we see that there are ankyloses on both the sacroiliac joints. However, if you look at the stir sequence, absolutely nothing. So this gentleman, again, if you were to put him, classify him, he cannot be classified for a trial. However, he has to be treated aggressively for his structural disease. Now, let's talk about radiography and what is the role in current scenario. We go back to 2 cohorts of axis spondyloarthritis, basic cohort, which was patients with inflammatory back pain of less than 3 years, between the ages of 18 to 50. In that basic cohort, when they read the X-rays, they found that only 13.5% of 700 odd patients had definitive features of radiographic sacroiliitis. Space cohort, which is again SPA-COT early cohort, which is early, just undiagnosed back pain of less than two years. There again, when they went back to the radiographs, of the 500 patients, only just about 10% of them fulfilled modified New York criteria. So we know that radiography has a poor sensitivity. Moving on, when we have trials, we have a central reader who is supposed to be an expert, and then we do have local readers who also have access to clinical data of the patient, which we say is the gold standard, because combining clinical data as well as imaging is how we make a diagnosis, again, of axis spondyloarthritis. But in the basic cohort, way back published in 2014, they realized that the kappa rating between 2 central readers, which are known to be experts, was just about 0.54. And moving on to classic study, and this is actually an unpublished data which is presented just recently from the ASAS group, which has been doing this study over the past few years, trying to re-evaluate the 2009 ASAS classification criteria. About 1,051 patients have been included. And here again, if you look at the central, the reliability between the central readers, the kappa reliability is only meager 0.516. However, we conducted in the Copenhagen group, we had a EUROSPA study in which we were trained, 22 people were trained over 6 months on how to read both MRIs as well as radiographs. And then in this exercise, we see this is presented as an abstract. It's almost ready to be published. And we see that there has been a consistent improvement in the ICC as well as kappa among the trained readers. So it's a bit of a back and forth kind of a thing when we have, sometimes you really do well and sometimes it really fall apart from the other scores. So it's quite an unreliable exercise when you talk about X-rays. So now this was again a study done in the Charité University in Berlin, in which they included 169 patients diagnosed to have axis spondyloarthritis, and they imaged them with X-rays, low-dose CT, and MRI. And the gold standard for diagnosis was the physician's diagnosis. And they compared each of these modalities along with the combination of these modalities for the diagnosis for the gold standard. And we see that MRI had a very high sensitivity as compared to X-ray, which is only about 66% versus 82%. And combining X-ray and MRI also didn't really reach that sensitivity. Of course, CT would definitely be the best, but definitely MRI had a very good sensitivity, and specificity was the best for CT. So what we need to understand is there's nothing which an X-ray can pick up, which an MRI cannot. So the whole question is giving away, conventional radiography, not probably in our clinical practice because of the availability and the cost. These are 2 factors which still kind of limit the role of MRI in clinical practice. Now, when we talk of MRI of SI joints, we need to have a clear understanding of inflammation and structural damage. Its use has been, it started off as diagnostic evaluation, but now it's some parts of the world's used for monitoring. And of course, it's a sensitive outcome measurement tool. Early selection of biologic DMARDs is quite, MRI has a fantastic role to play. And especially we know that with the structural progression and reduction of structural damage, we know that the role of MRI has been pivotal for that as well. And this, another study which was in which the whole point of MRI has always been, the major critical point was, is not good for structural lesions. And with this in mind, again, this study was done in Berlin, in which they compared, CT was the gold standard, and they compared radiography and MRI against CT, and they found that MRI had a 0.85 sensitivity against CT and a specificity of 92, which was definitely better than radiographs. So coming to consensus, now, so far we've discussed the basis of what we do and why we do. And now we move on to the MRI sequences. I won't really dwell too much into this in detail, because this in itself can be, and there are a lot of questions which can come through in this space. So I'd like to touch upon what we as rheumatologists should expect our radiology colleagues, or whenever we get a film, these are the basic things which we should look for in MRI. What the consensus talks about 4 sequences which are mandatory, 3 of them in semi-coronal plane. Now, before I move on, I'd just like to touch upon how do I figure out whether the film, because most of these films won't have anything written around them, and all we see is, you know, some films or pictures this way. Now, the only way to diagnose, the best way is to see that if a film is a semi-coronal plane, you can see this foraminae, which, if you look at the inclination or the angulation of the SI joint, and if you take the same angulation, you get to see these foraminae, whereby a coronal plane won't have these foraminae clearly in the films. So we need to have 3 in semi-coronal plane, which include a T1 weighted sequence, which is sensitive for marrow fat, which could be a T1 echo, spin echo, a T2 weighted, or it could be a stirred or something equivalent, and a sequence design. So this is something which is just coming up, which is of great importance, and especially in the new trials run by ACES, especially the AXIS study, which is understanding axial PSA. This is a mandatory sequence which has been added, and this is a sequence which is designed for optimal visualization of the bone cartilage interface, and that's one part which actually T1 and T2, if you look at it, it doesn't really give much of information. But with these new modalities, which are basically chemical shift modalities or sequences, things like Vibe, Dixon, all these things have fantastic interface visualization, which is given a better visibility for erosions in the latest images. And of course, we need to have a T2 weighted sensitive in the semi-axial plane as well. So most of them fall in the semi-coronal, and as well as we need to have at least 1 in semi-axial. So when you talk of these semi-coronal and semi-axial, I thought this would be a good way to put it across. This is the joint we are interested in, and like what I mentioned, the angulation should be kept in mind over here. But if you look at the coronal plane, what we see is this would be the coronal plane, and that will be kind of perpendicular to the joint. But here, this semi-coronal plane aligns pretty well with the sacroiliac joint, or the facet, what we are really interested in. And this would be the other way, which is, and both these things are based on the S2 vertebrae. This would be parallel, and this would be perpendicular to the S2 angulation. And this is, again, pretty much the same thing in 3D reconstructed model. So if you were to, so the other thing what we need to always remember is to, whenever you look at the films, you need to have both the water sensitive as well as the fat sensitive, both on either sides of a bigger screen. and scroll it from anterior to posterior and posterior to anterior. And we get the best view as we move on anterior to posteriorly. And we need to have a comparison of both the T1 and T2 or STIR image side by side. So if we were to start over here, this is where we start. This is the anterior most part where we see the just about the bone over here. And the ileum is just about seen there, and we move on. And that in the schema, you see the line which is corresponding to it. Now we see a bit of sacrum coming up. And as we move posteriorly, we get to the middle of the joint. And then again, we move posteriorly. We see the first part of the ligamentous structure coming up over here. So this, from this part onwards, that is where we stop and we go anteriorly. So this is our bound, at least for inflammatory purposes, this should be our boundary. We stop here and we take anteriorly. So all the way from anterior to posterior till we reach the ligamentous, the first slice which has the ligamentous portion coming up, which is the posterior slice, that's where we kind of stop. And of course, these are important, but not in our diagnosis of sacroiliitis. So now I did mention about Dixon images. Now this is actually, it's just a comparison of what we see in T1 weighted image, where we see a few erosions. My level of confidence won't be really high. Of course, this is a definite erosion, but here we see that it's poorly demarcated. And this here we see a small kind of irregular line, which could be a fat metaplasia and erosion cavity. But if you look at the Dixon cavity, both in phase and out of phase, we see that these erosions are clearly visible here. And here we easily see a backfill, which is fat and erosion, which is a structural lesion, which was added in 2016. And if you were to compare that with CT, we see that it's pretty much similar to the CT images what we have for the same patient. And over here we do have our doubts regarding the erosion. So we know that as we progress with the sequences in MRI, we are getting closer and closer to the CT without any radiation required. So what are the things what we look for? We have inflammatory lesions, we have bone marrow edema and inflammation at the site of erosion. And structural lesions, we have fat metaplasia, we have bone erosion, fat metaplasia in the erosion cavity, which I mentioned as backfill, and of course, ankylosis. I'll just run through these lesions quickly. Also mentioning what are the things which you need to be mindful of when we look at BMEs as well, or any of these lesions for that matter. So here we have a T1 sequence, a STIR sequence. How do we make out the difference? Again, we see the fat, look at the fat is suppressed over here. However, the fat is quite visible, bright in a T1 sequence. And if you look at the sacral interforaminal BM signal, and this would be the reference of the assignment of the normal signal bone marrow edema, and anything brighter than that can be taken as a BME. And a subchondral region of cartilaginous portion is, now that is the most important thing. It should be subchondral portion of the cartilaginous side, which is most frequent lesion, seen up to about 60% of patients. Now, this was way before 2018. And 2018, Uli Weber and his group were the first ones to come up with false positivity of axis spondyloarthritis patients diagnosed based on the BME lesions as mentioned in the ASS criteria. They took recreational runners, elite hockey players, and of course, healthy controls and patients with axis spondyloarthritis. And they found that in recreational runners, about a third of them did fulfill the criteria, which is as mentioned in the BME, as mentioned in the ASAS criteria for BME, as well as close to about half of the elite hockey players also classified positive for the BME as mentioned in the ASAS criteria. However, and this was really the start of a series of studies in which they looked at multiple populations, not AxSpA populations, and they found similar lesions. But what was interesting to note was the position of these lesions, which was mostly posterior lower ileum over here. and anterior sacrum. So if you see a bone marrow edema in the anterior most segment in the sacrum, as well as the posterior most in the lower ilium, these could be, so here we can see that really clearly. Over here we have the posterior ilium and the anterior sacrum. We note that these could be a false bone marrow edema because of multiple reasons. And then, like what I mentioned, the next set was a French study in which they looked at pregnancy and what happens, association of parity and bone marrow edema of the SIJ, and they realized that it's the same thing. And in early postpartum, we see that quite a third of them do have significant bone marrow edema. When I say significant, it kind of classifies as ACEs positive bone marrow edema, as well as in late postpartum. However, we see that a quarter of them could be classified as ACEs positive MRIs. However, if you look at the erosions, we see that it's not as bad as what you would expect in axial spondyloarthritis patient, and ankylosis was none. So bone marrow edema was the worst or the maximum in early postpartum as compared to nulliparous as well as late postpartum, and BME appearance disappears, or the presence of BME disappears as the time from delivery progresses, as like, for instance, so generally when we talk about pregnant women, how to image or when to image, generally the cutoff is beyond 1 year is something which would be something closely required or recommended. Now, bone marrow alone, like what I mentioned, lacks specificity for sacroiliitis, although it's quite sensitive. So we need to, again, back to the pretest probability, anatomical location, and extent are the things we need to really think of when we interpret a bone marrow edema. Fat metaplasia is T1 in T1 weighted image in the film, which is a bright signal. Two things over here, what we need to be aware of is the extent. It has to have a very distinct border, as well as it has to have a homogeneous appearance. So these two things are very important, because as we know that as age progresses, the erythropoietic marrow is shifted to the red marrows into the white or the yellow marrow, and that's where you can have groups of these so-called homogeneity. However, you need to have a homogeneous with distinct margin. That's what is important for fat metaplasia. Again, people got smarter. They did in normal population. They found the same thing. This was in the Berlin Charity group, again, in Katrina Siebler's group, in which they did, with the age they imaged, and they found that fat metaplasia was present in less than 45 patients. In less than 45 years, they were present in 50.6% of normal patients. As the age increased, they found that it's almost close to 100% in 75 years. So this was a huge number in which they imaged around 500 patients without a diagnosis of axial spondyloarthritis. Same thing, this is a colleague of mine who did a PhD in which she looked at the morphological and the anatomical features of the lesions of sacroiliac joints. They showed that fat metaplasia, again, if you look at the scores, here we see that fat metaplasia was found in 37% with inflammatory back pain without radiographic sacroiliitis versus 15.3% healthy individuals, and in 19.2% with non-specific back pain. But what is interesting again is if you look at the scores, as the scores progress, as in like if you have just one lesion or a single score for fat metaplasia, the chances are more for the other normal individuals to be classified as axial spondyloarthritis. However, if you look at more than 10, we see that 44% over here and almost none as you look at the other normal individuals, which included postpartum women with pain, without pain, hospital cleaning staff, long distance runners, and healthy men. So we know that as the lesions increase, your confidence level should increase for a diagnosis of bone marrow lesions of fat metaplasia. Bone erosions has been really tricky, especially with the old sequences, with T1 sequences. the best of the agreement between the best of the readers was around 0.6 in the last across the board, and we see that it's not as easy. So that is something which has to be worked out for an MRI. Fat metaplasia in erosion cavity, this was added in the 2019 definition of the SS revision of the definitions, and this is what we talk about fat metaplasia, which essentially talks about a reparative process. We know that spondyloarthritis has both erosions as well as bone formation, so osteoproliferation as well as osteolysis or erosion. So that is precisely what is picked up by this particular fat metaplasia in erosion cavity, where we see a complete loss of dark appearance of the subchondral cortex at its expected location, and a clearly demarcated, which is clearly demarcated from adjacent marrow, and an irregular band reflecting sclerosis at the border of, you need to have a sclerotic margin. So we're talking about this fine line, irregular line in between two sclerotic margins, if you look at it carefully. So this is a very good schema which explains what exactly is we're talking about. We have a normal joint here, which has an erosive damage, and then this is seen as an intra-articular high image in the T1 sequence, and then we have this is which is the fat metaplasia or backfill, and studies have shown that these are the patients, some of them at least, progress to ankylosis as the bone repairs on itself. We do have bone sclerosis, which is often masquerada for the diagnosis of spondyloarthritis in most of the cases. We have ankylosis and bone bud. So these are a few of the definitions which we need to be pretty familiar with when we talk about axis spondyloarthritis imaging. Now, structural lesions provide contextual specificity. We need to have a bone marrow edema to be sensitive, and then we need to have structural lesions which show a gradual transition from focal to extended bone remodeling. And then we have a contextual interpretation with erosions, which increases the confidence. And of course, erosions, ankylosing, and backfill, these three are most specific for axis spondyloarthritis and generally seen only in spondyloarthritis patients. Anatomical distribution, people have looked at the anatomical distribution of MRIs and see if we can predict where can we get the best buck when we talk about diagnosis of a particular patient or diagnosing a particular patient as spondyloarthritis. We have bone marrow edema, which, like what I just mentioned, it's very common. However, it's rarely bilateral, except in postpartum women with back pain. Fat lesions, actually, if you look at it, it's mainly in axis spondyloarthritis patients, but mostly in the sacral quadrants. Now, here I'd like to walk you through this figure, which looks pretty good and it has a really important message as well. So these are the anterior slice to the posterior slice in patients who had axis spondyloarthritis, which is the blue one, women with postpartum pain, women without postpartum pain, disc herniation patients, cleaning staff, long distance runners, healthy men. So this is the pieces I was talking about by Schengel 7, who did multiple studies on these patients. Here we see, what we see here is as the lesions in the other healthy groups are more in the anterior slices, and as we move to the posterior slices, and so from the middle onwards, it's mostly quite specific for patients with axis spondyloarthritis. So from the middle, so anterior, like what I mentioned earlier for bone marrow edema, that is kind of it could not be, it could be some other lesions as well, but as we move posteriorly, right from the middle to posterior lesions, it's really specific for axis spondyloarthritis. And erosions occur very rarely in any other conditions other than axis spondyloarthritis, and is mostly iliac and often bilateral. And widespread fat lesions and or erosions in the central or posterior parts. So again, here's the same thing. The maximum lesions are seen in the center, where it's totally not seen in other populations over here. So morphological characters, again, the total depth is the other thing. So we looked at the anatomical distribution, the morphological lesions. We talk about the depth of the lesions for bone marrow edema, where we see, and fat lesions, of course. We see that this is again axis spondyloarthritis, and this is the depth of the lesion. We have more than 10 millimeters, and fat lesion more than 10 millimeters. So the deeper the lesion is into the from the subchondral margin to the bone, we see that it's more specific for patients with axis spondyloarthritis. I'll skip that. And so this was a predictive utility, which was a consensus definition for specificity of axis spondyloarthritis lesions. We see that more than 4 SI quadrants, BME at the same location in more than 3 SI sequences, and any one, which could be more than at least 3 SIJ quadrants with erosion, or more than 5 with fat lesion, or an erosion at same location. So essentially what all these definitions are driving in is the more the lesions, the more the specificity, and the deeper the lesion, the specificity also increases. So that's what we have in terms of diagnosis. And we also need to be wary of MRI negative patients whom we have highly clinical suspicion of axis spondyloarthritis. Like what I mentioned, I would definitely, if I have a very high suspicion of axis spondyloarthritis, I would wait for almost a year, especially in patients with a history of delivery over the past 1 year. I'd like to wait a year before I re-image them. We need to understand that all that glitters is not gold. So what happens with MRI is more of a circular kind of a reasoning here, because we start at a point and we kind of most often come back to the same point, because there's no objective reference standard. And then that's one of the reasons why we misclassify. It has limited specificity, limited sensitivity. However, it's very useful diagnostically. What we need to understand is we need to understand to recognize patterns and the differential diagnosis. A whole lot of differential diagnoses need to be considered when we talk about reading spondyloarthritis images, and these things have to be kept at the back of our mind. Again, this should start with, I just go back again to the probability of what is the probability of the diagnosis before ordering a test. What are the pitfalls? We need to be mindful of the coil effect, phase encoded motion artifacts, blood vessels, normal marrow changes, and of course, general population and patients with chronic non-specific back pain. But one of the most important things which I've learned over the years is how to speak the same language with our radiologist. It's important to have constant interaction with our colleagues, our radiology colleagues on the other side, and that really brings up the confidence both for the rheumatologist as well as for the radiologist. And we always have a patient at the center of care and a team working around that patient to solve a particular problem. And once we get into that phase, I think it's easy to have that dialogue with the radiologist, because and we learn from each other and we have better agreement in diagnosis, both in terms of radiologists as well as rheumatologists. And this is again ACE's project, in which should be soon published, in which Thorsten Dieckhoff has come up with some of the checklist. When we order an MRI, what should be the details which a radiologist would prefer? And when the radiologist reports back, what would the rheumatologist expect in terms of a diagnosis? Often I've seen radiologists making a diagnosis of axis spondyloarthritis, which is totally wrong. And again, the same thing with rheumatologists. When we order an MRI, back pain, rule out sacroiliitis. That's the only, so it's very difficult for the radiologist to understand what is the back pain. So essentially, at least from my point of view, there should be at least age of the patient, the gender of the patient, duration of pain, HLA-B27 status if possible, psoriasis, and maybe enthesitis, dactylitis. If we have details on that, that should be included. And of course, laboratory tests. So the more details we provide the radiologists, they will have better confidence in diagnosing axis spondyloarthritis. And of course, when we often have doubts, we call across And I think that kind of a dialogue sets a lot of things sorted out. So what are the salient takeaways from today's lecture? One would be MRI alone cannot diagnose axial spondyloarthritis. We need to understand a pattern recognition is what leads to specificity of the diagnosis. Contextual assessment of structural as well as inflammatory lesions need to be considered. Morphology and combination of lesions add to the specificity of diagnosis. And of course, we need to be wary of anatomical variations, differential diagnosis, and the most important is false positives. Thank you very much for your patient listening, and be happy to take up questions.
Ashish, I am Dr. Rohini.
Hi.
Hi. So I have a patient who has actually osteitis and condensans ileae, and she has a very typical presentation of inflammatory back pain, and which was really difficult to manage without NSAIDs continuously. And for the last about 4-5 years, at least 3 years, I think she's on TNF alpha blockers and doing well with the same. And I did read up about, sometimes osteitis being a condition which can be very close to, ankylosing spondylitis.
Absolutely.
And just your comments on this.
So, two conditions which I'm really scared of, in fact, if I were to put it, is one is OCI for sure, and the other one is DISH. Now, these two conditions can really coexist with axial spondyloarthritis, and it could be a bit of a challenge, one, to tease them out if they are not, part of axial spondyloarthritis. The reason why I'm saying is, we used to say that it's easy to diagnose OCI because it's mostly sclerotic in both T1 as well as T2, which is true. But even in T2, in OCI, I'm talking about just pure OCI patients, 30% of them can have bone marrow edema. So then you're stuck, right? And you have a bone marrow edema, you have sclerosis. But here again, what we need to look out is for erosions. Now, there are studies which have shown that at diagnosis, up to 60%, well, depends on when the patient is diagnosed, but at any point when the patient is diagnosed, the patient already has a fair amount of erosions if it is axial spondyloarthritis. Now, that is very important. Once you see erosions, fat metaplasia, and backfill, and there's a whole lot happening in the structural progression area and the role of MRI. So that's another lecture on its own, but it's fantastic because we've known that TNFIs have been helpful. Now the studies have shown that IL-17s have been helpful. But I'm coming back to the point. I think the way we should differentiate them in imaging, if you look at it, would probably by the presence of structural lesions and not purely by BME, because 30 to 50% of them do have significant BME along with OCIs. And of course, the position is very important. Once you have posterior lesions, it's more of an axial spondyloarthritis as opposed to OCI. But having said that, there are conditions where both these things coexist. And probably this patient could be, especially in women. And that's one thing which has come up with MRI, because earlier it used to be like, AxSpA is only in males, women don't have AxSpA. Now this whole concept of non-radiographic axial spondyloarthritis have come up, which is in fact is the same spectrum. When we realize that, women and men can be affected equally, almost. So this could be a problem, especially in postpartum women or even nulliparous women, because of the structural lesions. And we have studies coming up with the anatomy, which can predispose to erosions as well. So I think we need to consider all these things when we deal with a patient of, having both these things together. But Kavita, I think I'm not able to hear you. I think you're muted. Okay.
Yeah. Thank you for an excellent talk. I just wanted to ask, in sportsmen, you said that, they get better with physio and there are like false misleading signs. So when they get better, they go back to their activities and again, they're likely to get symptoms. So how do you monitor them? How you recommend monitoring them?
I think it's patient education, which is more important, and physio, core strengthening exercises. What I wanted to stress through that point is not to keep on ordering MRIs, because I've often see patients who keep coming, keep getting, I won't say keep doing, keep getting MRIs done every 6 months, right? And then you're in a fix. Every other MRI will show. And whatever happens, like this inflammatory lesion, which is the BME, cannot be BME forever. It moves on, and then it could be a fat metaplasia, maybe 6 months down the line. So as it progresses, I think we need to recognize the fact that it could progress, and it has to be recognized that way. So there's no point repeating MRIs in such people. And especially if you look at the locations, that is very specific for sports people. But when it comes to clinical care, I think they need to be mindful of not falling into getting frequent MRIs. So I think patient education goes a long way into all these things.
So when a young rheumatologist or postgraduate, they order an MRI for suspected axial spondyloarthropathy, so should they give any specific instructions? T1, T2 stir, all are equally important, or?
So that's so two things here. I did specify that. One was what are the clinical details which should be provided?
Yeah,
one, of course, you need to have a good suspicion of the disease. Your pretest probability should be pretty high. There we start, and then we have to give clinical specificities. And of course, T1, T2, like what I said, at least there should be 4, at least 3. I don't think we've reached, most of the centers may not, or some of at least centers may not have, Dixon images. This has been going on for years, because we've kind of borrowed it from GI sciences, where they had this periportal fat and all. So it's basically how to differentiate fat and water kind of a thing. And this has been going on, and we've kind of borrowed them from GI sciences, this whole sequences which are upcoming now. So at least we need to have a T1 and T2, T2 sequence and a semicoronal. So most important thing is a semicoronal and semi-axial. And we need to have a T2 or something relevant accordingly, a T2 fat suppressed or a stir, and of course a T1 to figure out the structural lesions, and a T2 or a stir for semi-axial. Because semi-axial, the reason why we do is that helps us to differentiate these so-called normal people with MRI as from the real axial spondyloarthritis patients. And for them, I think having a semi-axial is very important.
Do you recommend follow-up MRIs after treatment? The patient says, doctor, have I got better, or it should just be clinical?
Yeah, the question is, what are we looking at when we repeat an MRI? We can show the patient, hey, what the BME, what was there is gone, but what happens to that BME, we don't know. Like, so some of them go into erosions. That erosion fills up with the cavity gets filled up with fat metaplasia, and then some of them have ankylosis. So, of course, in clinical trial settings, we do have serial MRIs. For research purposes, we can do serial MRIs to understand what happens to the lesions. But in clinical care, I don't think it's really needed, unless we say that there are a few situations where we can do is probably when you have the amount of inflammation is inversely proportional to the extent the patient would get benefited. So again, in our setting, in our clinical practice setting, I wouldn't recognize asking for another one, because it costs 10,000, 15,000 rupees. I would rather give 2 doses of adalimumab for the patient with that money than going on for another repeat MRI.
So one more question. The patients who come late, they already got an ankylosis on X-ray itself, and they're fitting in with all criteria for axial SPA. So should we really ask for an MRI, or we can just treat them upfront to shave?
Here again, yeah. The question back would be, what is the aim, right? If your aim is only to diagnose, all you need is a grade 3 unilateral or a grade 2 bilateral. Good enough. You got the diagnosis, you treat. But if you look at the extent of the lesion and what are the lesions, and if you want to plan your treatment carefully, I think that is where I would recommend an MRI, but not for diagnosis. So, for instance, if somebody has a BME or a large amount of structural lesions, whereas not much of BME over there, still, I mean, like there's a role for structural progression, not arrest, but at least to bring down the structural progression. That is probably, if you were to consider how long to treat, with what to treat, all these things, I would certainly ask for an MRI, but not for diagnosis.
Okay. Anybody else? Any questions? Okay. Thank you so much for joining us
Thank
today.
you. It was a pleasure.
Yeah. Thank you so much for spending time on a Sunday morning. Yeah.
Always a
Hope to
pleasure.
interact with you again. Thank you. Bye-bye.
Thank you. Thank you. Bye-bye.
Thank you, Ashish. Yeah.
Thank
Thanks.
you.
Thanks.
Yeah, bye, Rohini. Yeah. See you.
Bye.